Dr. Naren Kumar Kushwaha to chair the person. Dr. Kumar Keshav and Dr. Mayank Mahindra as panelists.
I'm already here.
Dr. Ramakant is already there, so
Excuse me.
Dr. Sunil.
Slides. ऐसा ही आएगा? So, good afternoon, everyone. Thank you, organizing committee, for having me here. So, in the series of talks on dysplastic hip, I'm going to talk about a basic approach to a dysplastic hip. So, once you diagnose a case of dysplasia, first thing is that what is the degree of dysplasia? You have to classify it, because that degree of dysplasia will dictate the complexity of reconstruction. So there are two classification systems which are very popular. One is Creutz's classification, which is basically an X-ray based classification system, and it is like displacement of the proximal femur in relation to the teardrop. But the biggest disadvantage with Creutz's classification is it's based on X-ray, so it gives 2D assessment of a 3D problem, and there is a lack of correlation with the anatomy. So to resolve the issue came the Hartog-Filakidis classification. So basically this classification is based on 3D CT scan findings. It's better in the terms that it guides surgical management by integrating the surgical findings and anatomy. So once you classified, so which classification is better? I mean, there are multiple studies which says that both classification systems are reliable and there is no significant difference. So once you classified, then you have to anticipate the problem, what problem you can have during surgery. So basically dysplastic hip, the anatomy is totally distorted. So you have to anticipate those anatomy. So for that you need basic AP and lateral view of X-rays. But since this is a 3D problem, X-ray is not going to give you adequate diagnosis and adequate information. So you need 3D CT scans, 3D recon CT scans that will give you adequate information about the dysplasia of the hip. So 3D CT scan gives adequate idea about the deformity, the segmental defect, the anterior posterior coverage, and the bone stock, the medial bone stock. So you need to have a 3D CT scan for adequate information about a patient you are going to operate. So what problems you can have? Like on the acetabulum side in dysplastic hip, your acetabulum is shallow. There is normally poor anterior and superior wall coverage. There is superior bone defect. Acetabulum sometimes are retroverted. On the femoral side, there is short femoral neck. There is posterior greater retrocantler overhang. There is anterior bowing of the proximal femur. Sometimes there is excessive femoral anteversion. And the canal is sometimes narrow mediolateral canal. So these are the problems you have to anticipate before going to the surgery. Is it the only bones? No, it's the soft tissues also, because the abductors are poorly developed. Adductors, psoas, hamstrings, they are usually shortened. Sciatic nerve is at danger, particularly if you are lengthening the limb, and the capsule is redundant and elongated. So these are the soft tissues and bony problems you have to understand and anticipate that these things are going to happen. So do we need special instruments? Yes. Like the acetabulum is shallow, so you need small dia cups, like cups beyond 40 mm sizes. You need special implants, like sometimes TM cups, sometimes custom-made implants, sometimes restoration rings to fill up the defect. You need screws and allograft or autograft to take care of your bone defect. So special implants are needed for the acetabulum side, and so is on the femoral sides, like specific stems, like in like type 2, type 1, type 2, you can go a bit with normal stems, small dia stems, but on the higher side, you need some special stems. So tapered conical stems are favored one, while where there is excessive femoral anteversion, where you need to change the anteversion, you need to have a backup of modular stem like SROM. So there are multiple options to reconstruct or improve cup coverage. Either you can use autograft, allograft, You can do a spongioplasty, cotyloplasty, and you can use special implants. Femoral preparation, usually it's straightforward in type 1 and type 2, while type 3 and type 4, you have to bring the femur down. For that, we need to do subtrochanteric femoral osteotomy. That takes care of limb length discrepancy, and it reduces the amount of soft tissue releases. But it's better to avoid limb lengthening more than 3 to 4 centimeter. So these are the steps. We do subtrochanteric osteotomy. So cases like few examples, 55-year-old male with grade 1 dysplasia. You can see the CT scan findings. There is poor anterior wall coverage, greater trochanter overhang, but the posterior wall is preserved and intact. So these are the axial and coronal cuts. So we get away with aceromostem, 44 dia head on the stapler side, cup, and the aceromostem on the femoral side. So these are the 4-year follow-up X-ray. Another case, bilateral dysplastic hip, multiple time operated on the left side. These are the long leg films. Intra-op, first we planned for aceromostem, but we noticed a fracture during placing the sleeve, so we have to change it to dysplastic chorial stem. After even putting the dysplastic stem, the reduction was not stable, it was impinging, so we have to reposition the cup and insert the screws before final trial. So these are the post-op X-ray, 1, day 8, and 6 weeks X-ray. These are the long leg films. Another case, 42-year-old male, dysplastic hip, type 1, on the right side, managed with good metaphyserum prosthesis. So the take-home message is it's a technically demanding surgery. You need to give meticulous attention to distorted anatomy. You need to have the special implants. Try to restore original hip center and consider subtrochanteric femoral osteotomy in type 3 and type 4 dysplastic cases. Thank you.
Our next speaker is Dr. Tomar on tips and tricks of total hip arthroplasty in complex dysplasia of hip. I quickly invite Dr. Dharmen Kumar to be on the dais to be a panelist.
Good afternoon, everyone, and thank you, organizers, for this opportunity. And most of the things have already been covered by the previous speaker, but I would like to skip those and will focus only on the complex grade 3 and grade 4 type dysplasia hip. So these are type of the complex hip which falls into the category of grade 3 or grade 4 in say grade 4 dysplasia and have all complexities of hip dysplasias. So as you already have been discussed, it is equally to CDH post-infection or post-trauma in early childhood. The dysplastic hips anatomy is completely changed. There is altered high biomechanics has already been discussed by the previous speaker. The classification has been discussed. And the surgical consideration for these cases is evaluating the preoperative limb length discrepancy. Relocating the hip center is of paramount importance, and predicting the use of shortening osteotomy and implant choosing is, of course. Templating is very important in these cases, but templating is done on the pathological side only and not on the normal side, because we are not trying to recreate the normal anatomy, but the templating is different here. Full length AP is radiographs, scanograms are taken to identify limb length discrepancy, pelvic obliquity, scoliosis, implant size, and other things are noted. And same way, we look for the size of the implant and the osteotomy site to be planned. CT scan role has already been told by the previous speaker, important for prosthetic selection, bone stock, acetabular implant cup sizing, it is important. And this bone is thicker on the posterior side. So reaming has to be done on the posterior side only, and all efforts should be made to protect the anterior column. Say CT scan also we can determine about the retroversion of the cup, how much it is, and about the femoral anteversion also. So a little bit about surgical steps. Posterior approach is preferred for grade 3 and grade 4 dysplasias. External rotators are identified and tagged. Visualize the sciatic and protect the sciatic nerve. Release adductors, iliopsoas, excise all capsule around, and identify the inferior margin of the native acetabulum. Then we prepare as was already described by Dr. Vijay also in some previous discussions. First, we prepare the proximal femur. Neck osteotomy is done, and prepare the proximal femur reaming is done, and fix the sleeve there. Then try to bring down the femur down till acetabulum. If it is not possible, straightway we do the osteotomy at predetermined level, and after this, the acetabular exposure becomes very simple. So then, of course, the acetabular changes has already been discussed, shallow, hypoplastic, deficient bone anteriorly, laterally, and our aim is to place the cup at true native acetabulum. High riding hips are acceptable but not desirable. So acetabular changes, again, it is bone deficiency superolaterally. Cup remains, when we try to fix cup remains uncovered. 70% coverage is required. We can take the help of acetabular augmentation, bone autograft, porous metal augments, or sometimes we can medialize the component also to have this 70% coverage. So these have already been, so this slide has already been shown. So it should be reconstructed into native acetabulum. Small acetabular cups have to be ready, and 70% horseball contact is required, and uncemented cups are preferred. So coming to the femur side, there is excessive neck anteversion, and that is posterior displaced greater trochanter, valgus neck shaft angle, hypoplasia of the intermedullary canal, and there is a gross rotational metaphyseal mismatch. So to overcome that, we have to take the help of subtrochanteric osteotomy, derotation osteotomy. It rotates the proximal fragment to bring metaphyseal flare and greater trochanter into a more anatomic position and restore the function of abductors and correct the femoral shortening and eversion. So uncemented are preferred in this case, and for complex hips, this is the modular femoral prosthesis with proximal sleeves, and this implant allows to adjust the medial offset, vertical height and version even in excessive neck shaft angles, and proximal sleeves give greater initial stability with the shape of steps and porous coating, and stem is also fluted, give greater stability. So these are the femoral reconstruction pulse. More than 60% anteversion is there, always perform osteotomy to optimize the trochanteric position, and this anteversion can be corrected by derotation osteotomy with or without femoral shortening. So this is case 38 years old female, sustained fracture early childhood, non-union, and you can see all the complexities of complex dysplasia hip, shallow acetabulum, deformed proximal hypoplasia of the femur, and this was managed by using small size uncemented cup and derotation osteotomy fixing with the Astrom stamp, and simultaneously achieving, and this was stable, and patient was able to walk within 48 hours with good results. And this is another case, this young female of 27 years old, and this suffered septic arthritis early childhood, multiple surgeries, and you can see here that complete all the like deformities of the dysplasias, severe dysplasia, they are as CT scan is of great help. So acetabular cup size was smaller size acetabular cup was used uncemented, and from iliac crest graft was taken to take care of the superolateral deficiency, and the femoral part was smaller size stem, Astrom stem was used, it was not stable, so the stability was achieved with grafts and the plates. And the post-op X-ray was quite looking horrible, whether it is going to survive or not, but this is 6 months post-op X-ray. The good formation, young patient, good formation of bone, and sorry. And this, the previous slide was showing this video of second day walking, and then 2 weeks walking, and 6 days. Patient was after 6 months, patient was able to walk. Yeah. This is within 48 hours, patient walking with support as weight as tolerated. This is 2 weeks walking video, and this is at 6 months walking with stick support only. So there was good formation. However, post-operatively it was looking not very satisfactory. Per-operatively it was good. Thank you very much for the patient hearing.
The next speaker is Dr. Ashutosh Srivastav. Thank you, sir. Dr. Sunil Kumar to please come to the dais to chair the session. Dr. Ashutosh Srivastav. Okay. Dr. Devashi Rastogi.
So good afternoon, everybody. I'm going to present this case. This is a 22-year-old female presented as a case of dysplastic hip right side with weakness of both lower limbs, with bilateral CTEV, with shortening of right lower limb. And she had the complaint of pain over right hip for 2 years, difficulty in walking for 2 years, and limp since childhood. And she started walking at the age of 10 years with support. She was also having neurogenic bladder and got operated for urethral stenosis in 2014. And she had motor axonal neuropathy of both lower limbs. On examination of right hip, she was having waddling type of gait, and all the hip movements were normal and shortening of 4 centimeters. The muscle charting shows bilateral hip, there's weakness of both lower limbs, and knee was normal in both lower limbs, and there was absence of movement and on the ankle, toes, and she was having bilateral CTV. And this is the pre-op video showing the waddling type of gait, and she was putting a lot of efforts while walking. So we got the investigations done, pelvis with both hips, CT scan just to get the bone stock available, MRI to suggest any sort of evidence of compressive or T-third cord syndrome, NCV showing motor axonal neuropathy of both lower limbs, ESR CRP was normal. On X-ray it was Crow type 2 dysplastic hip, it was subluxated and deformed femoral head, coxa valga, shallow acetabulum, and there was a sort of pseudoacetabulum was there, and deficient bone stock. So the problem in this case are younger age group, painful and unstable hip, weak hip joint, weakness of bilateral lower limbs, bilateral CTEV, muscle power is 0 at the ankle and foot, leg length discrepancy, and morphological changes of acetabulum and femur on the X-rays, and neurogenic bladder. So treatment options. We offered her first conservative management, for which we gave her orthosis. HKFO was given, but she was complaining of regular pain in the right hip, and she was not satisfied with the conservative management. The next options may be pelvic support or osteotomy, but I think that is not feasible in this case, since already the head is deformed and there is arthritic changes in the hip. So we gave her the option of arthroplasty. The pre-op planning was to aim to relocate the hip center, getting combined anteversion right, choosing appropriate implants, stabilize the hip joint, correcting leg length discrepancy, and we also plan to offload the weight bearing by certain orthosis, and just to get the early rehabilitation done. So these are the armamentarium which we required in the OR, like the acetabulum side, mainly highly porous cup, and we also keep small size cup ready, and highly cross-linked poly, femoral head autograft just to meet out any sort of defect, and femoral stem, both uncemented as well as cemented stem were there. So this is the immediate post-op X-ray, And this is the video of the same patient after 1 week. We gave her HKFO just to offload the implants, and so that we can provide her early rehab also, early mobilization. And we use this 46 highly porous cup. This is at 3 months follow-up. Now she is walking effortlessly, without effort, sorry. And she's using this walker. So in the coming months, we are planning for AFO, just to switch from HKFO to AFO. And let's see what happens with this patient. So this is the, thank you. So your suggestions, please.
Kindly take a seat, sir. Now invite Dr. MC Saini to present his case on fused hip and its conversion to THR.
Good afternoon, everyone, and thanks to Dr. S. sir and our organizing team to inviting me on the discussion on fused hip. Introduction, femoral head and acetabular fuse, the continuation of all trabeculae. And the various causes are spontaneous, inflammatory, infective, and post-tubercular dysplasia, post-surgical, iatrogenic. And arthrodesis is excellent pain relief in the stage of pathology at a cost of motion, but now rarely done. Improvement in treatment and better method of fixation, Hooks of THR, longevity hip implant. Arthro is ideal candidate for young and manual labor monoarthrosis of hip. Relative indication is a significant deformity around few neurological condition like polio. Disadvantage is poor quality of life, disability, and low functional level, pain in other joints. And conversion to THR is required because the improvement in quality of life, better fixation level, body mechanism, but it is challenging and risky. Indication is because of pain in ipsilateral knee and contralateral hip and spine, malposition arthrodesis and ipsilateral TKR, and fractures around hip. The discussion have to discuss the patient, the functional demand and expectation is little lower, less than of a normal THR. But fully explained about the nature and risk and counseling the patient is very important, complication of surgery. And these are preoperative, proper history, reason, and previous past discharge, and delayed wound healing and other joint involvement. And examine the patient as, but keep in the mind, important is the abductor. You have to be abductor, whether abductor is how much strong. You can do the MRI for the abductors and do the EMG. And there are various X-ray, pelvis, Judet view, cross table, CT scan, and scanogram. The templating, as usually done in previous lecture, is cup is not go to collar slide. And this is a lateral position. I usually prefer to the posterolateral approach in the lateral position. And posterolateral, there are various approach, posterolateral and retrolateral, and now the direct anterior approach is also is there. There is a paper is mentioned by the. And now the posterolateral approach, we cut the skin and direct cut the skin and TFL, and after TFL cut, you come directly over the sciatic nerve, because the external rotator is most of the time is atrophy. And in this case, a trochanteric osteotomy may or may not be. And the surgical technique in situ, you cut the neck osteotomy, you cut the neck, and again double cut of neck, double dome osteotomy is done of the neck, and second neck is cut at the level of subcapital region of the head, and soft tissue release, and retract the sciatic nerve. Sciatic nerve is visible over the pin at the ischial tuberosity level, and now this second pin is the abductor, for the abductor. Now, see start the reaming, acetabular reaming of the neck directly over the neck and relative to anterior and posterior column, and see the true floor, and you maximum time you identify the pulmonar soft tissue at the fovea centralis lesion. And you can also take a help for the C-arm. Initially, you start with the C-arm. Now the inclination, if the patient having a adduction deformity, the inclination is slightly low, and in abduction deformity, you take the inclination is little more. And femoral preparation as normal. And surgical technique, the trial reduction and stability, LLD, and offset, sciatic nerve tension, abductor and closure, and adductor tenotomy is done almost all of the cases. The complication is fracture, nerve injury, vascular, and post-operative dislocation, infection, heterotrophic ossification. And rehabilitation is slower than primary THR, and avoid the flexion 90 degree, and avoid adduction and weight bearing. Abduction strengthening is very important, and indomethacin prophylaxis for avoiding the STO, heterotrophic ossification. And conclusion, there is a conclusion in the fused hip cases to operate, rarely seen and is very complex and risky, but fully counsel the patient is very important, and residual LLD, limb length discrepancy are large, or nerve injury, 10-year survival, and functional results is inferior compared to the primary THR. Now the case number 1, 27 years old patient having a completely fused hip, infection, 17-year duration on history is the infection, and low functional level. And this is the preoperative walking. Now, after surgery, the cup is well fitted in the 45 degree and abduction angle and stem, and now the patient is able to squat and cross leg position and is normal walk. Now the case number 2, this is a 22 years old young male, complaint of 12 years pain, and HLA-B27 is negative, and both hip is affected, and this is the walking preoperatively. Now the both side is operated. Both side is operated. Now able to cross leg and squatting, and patient is able now is post-operatively able to walk. Now the 20 years old female and history 12 years and right hip in adduction is a bind swap deformity, and left hip is in abduction, and left knee is 25 degree of hip flexion deformity, and this is the preoperative walking, and both side are operated. Both hip is replaced, and now the post-operative abduction this, and this is the patient walking after post-operative. Now the case number 4, this is again both hip is affected, HLA-B27 positive, and bilateral abnormal position, both knee in FFD, and this is the case, and almost 90 degrees FFD in the knee, and this is right side is operated first. And now, because of knees fixed flex 90 degree, I keep on the traction initially, and this is the case recently done. Now, is the patient is on the skeleton traction, and I think to a 45 degree of knee is corrected. And if it is not corrected, it is corrected by tenotomy or either maybe capsule raise or either maybe extensor or bony osteotomy. Now the case number 5, 35 years old female, right side bony ankylosis, and left side is girdle stone was done. The patient initially patient is attempting for somewhere else. Now the patient is come to me as left side is girdle stone osteotomy, and with as having a posterior acetabular wall defect, and this is the case done by the right side initially done, and take a graft of the neck, and which is posterior wall is posterior acetabular wall is reconstructed on the left side, and which is done both hip. Now the patient is able to walk this way. And now the sixth patient, the patient is 19 years old female, complaint of 12 years, and FFD is 25 years knee. This is the X-ray, and patient is walking preoperatively. And after surgery, is replaced, left hip is completely replaced, and patient is now, after 1.5 months, patient is gone.
So,
the conclusion is this: patient is counseling is very important, and rehabilitation is delayed compared to the primary hip replacement. Thank you.
thank you, Dr. Sethi.